Thank you very much. I really appreciate your having me speak. And you know, I don't worry about those barbed questions. I figure I'm short. If they throw things, they'll probably miss me, so I'm okay. One of the things we met for dinner last night, and Bob Pizzatullo said, you know, to really connect with your audience, you need to open with a story. So all of the speakers were sitting there thinking, what can we say? What can we say? So I thought about this last night. I really did. And my husband came with me to Chicago. And so this morning he said, well, do you have your story? And I said, no, I really can't think of anything anybody'd want to know. And he said, well, why don't you ask how many people are divers? Are there people who are divers? There are a few of you. Okay, so if I say, plan your dive, what do you say next? Exactly. And he said, you know, I hear you talking to people on the phone because I work from home. And that's essentially what you're telling people. Plan how you're going to meet the standards and then do it. And I'm not a very successful diver. I have sinus problems, so, you know, I don't even do boat dives because by the time I get down, everybody's gone. So it's like, you know, forget it. So hopefully you'll do better with the standards. And was that a good enough story, Bob? I mean, you know, otherwise I got nothing. I got nothing. Okay, so let me see if I'm doing the PowerPoint correctly. So you all are aware that there were a number of standards that came out and were effective July 1st, 2015. Now you were probably also aware that pretty much very similar standards came out initially, I think in January of 2014, and were supposed to go into effect that year. Lots of feedback. People really said, you know, we don't have enough time. We don't know how we're going to meet some of these things. You're really going to impact patient care. We listened, went back, talked to accrediting other organizations, our accredited customers. We listened and went back and revised them. So what I'm doing today is instead of going over all of them, I picked out the ones that were really focused on dose optimization. So I'm pretty much going to tell you, here's what the accrediting agency is saying, and then the other speakers are going to tell you, here's how you can meet them. So I'm going to kind of help you plan your dive, and then they're going to help you dive your plan there. So there are 12 elements of performance associated with those revised requirements that really directly or indirectly affect CT dose optimization. And when you look at those standards, really all of the imaging standards, they pretty much have 3 areas of focus: the equipment, the personnel, and the processes. And it's the same thing for the CT dose optimization. So, you know, there's some definitions. I'm an old teacher, so, you know, you throw this stuff up. So looking at what dose optimization is, you know, the fact that you're trying to maximize benefit to risk ratio, but you got to have, it's not just dose reduction. You got to have enough dose to provide the diagnostic information that's required for that particular patient, that particular condition, and diagnosis, which makes it a little more difficult for you all to standardize, I think. So what are these standards I'm going to talk about? Well, they're accreditation standards. So they're not just for advanced diagnostic imaging accreditation, they're for hospital, ambulatory care, critical access accreditation. They're accreditation standards. And they include ADI. Now, I'll throw some questions out to you, and you can feel free to write them down. Somebody said to me, okay, so you have this advanced certification called Advanced Diagnostic Imaging, and there were a number of very similar standards in that Advanced Diagnostic Imaging certification. Now they apply to everybody. What's the difference? They're talking about it. You know, nobody thought about that at the Joint Commission, so now they're thinking about it. I don't know what the conclusion's going to be, but that's under discussion at the present time. So, will the survey process change? And this is what I'm sure you're going to have questions about. What about the survey process for these imaging standards? First of all, I'm going to tell you that the surveyors are the standard surveyors, and that means that Probably 98% of them are going to be nurses. That's going to be their background, nursing. And they're very experienced people, but they are not imagers. Thanks, Bob. I'll dance. Anyway, so they're going to follow the standard kind of survey that you've had in the past. It's going to be based on patient tracer. So you're not going to get a rad tech or a radiologist doing this part of the survey coming in. You know how they have an environment of care and life safety surveyors, and sometimes the life safety surveyor comes in, does their thing, leaves? Well, you're not going to have an imaging specialist come in, do this, and leave. It's going to be part of the general survey process and the patient tracer. So that's not going to change. And so as they follow a patient into CT or MRI or nuclear medicine or PET, that's when they'll be evaluating that imaging service. Right now, they're not going, as an aside to imaging, only if it's part of the tracer process. So that's where we're going with that. Okay, so again, if you're going to hear people talk about optimizing, and they're going to talk about the tools, which are essentially the hardware and the software. They're going to talk about the people that need to be involved to optimize, and they're going to talk about the processes. And the Joint Commission standards, again, pretty much follow that same pattern. So what I did, for those of you who may not, know these standards off by heart, including me, I got to have a cheat sheet because the numbers are like, I'm old, what can I say? Anyway, the first one that I think addresses dose optimization comes from the general standard that says the hospital manages medical equipment risks. Now, those of you who may have anything to do with the environment of care, this general standard covers everything from the gap under the door to the airflow to the trash in the room to the clutter in the hallway. It's all part of environment of care. So that's a very general standard. The element of performance that's specific to us is EP10, which says that the hospital identifies quality control and maintenance activities to maintain quality of imaging and so on and so forth. And I put another EP up there just to kind of bring it to mind that the Joint Commission is a deeming organization for CMS. And CMS says that for imaging equipment, you have to follow the manufacturer's instructions for quality control and preventive maintenance. So there will be surveyors who are aware of that, and they will ask you if you know what those are. So it's conceivable that a question about do you have the manufacturer's instructions, and that can be difficult to get for older pieces of equipment. FDA says they have to provide it, but it's pretty hard to get sometimes. So they're going to ask you about that. And actually, I'm going to have a question for Priya. I don't know if she'll be able to answer it in the ACR, because the questions come to me. The ACR has certain quality control processes that you have to follow. And if those are not the same as the manufacturers, do they have to do too? Or what do you do with that? So, that's a big question. And sometimes the manufacturer will address preventive maintenance, which is, one thing, and probably the biomed department will take care of that. And then you've got the more image-directed quality control and dose quality control, which is what the department's going to be responsible for. So, you need to make sure you understand that, and the people who are operating the equipment understand that. So anyway, here's the standard that says you got to have a quality control plan. Okay, so when the surveyor comes in, there's essentially two things they do. They follow the patient around, they interview the staff that they come in contact with, and they watch what's going on. So in this particular case, when they interview the staff, they're probably going to say, so what's your plan for quality control for this piece of equipment? And by the way, the standards only cover, these standards that I'm talking about, only cover the elements of performance, only cover CT, MRI, nuclear medicine, PET. So, we don't address yet standard radiography and fluoroscopy is our next biggie. We're working on fluoroscopy now. So you'll be seeing standards that affect fluoroscopy probably in the next year. I'd be surprised if we got them done before 2017, but you know, they may be effective 2017. So they're going to ask staff about the quality control program. And they're going to ask you, how did you put it together? Where did you get the information that you used to put this program together? So you can't just say you got it. You got to understand why you have it. So that's what they're going to be focusing on with interviewing the staff. And then they'll probably say, well, you know, that's nice. Show me. Show me the document. Now, it doesn't have to be a paper document, obviously. If you've got it online, fine. But you got to have something for them to see so that they can evaluate what they were told. You know, the big question is, how do you know? Well, show me. And, you know, they'll probably look at any policies that might relate to that. So that's kind of the plan your dive your plan, you know. The Joint Commission tells you what they want you to accomplish. How you get there is pretty much up to you. But if you say you're going to do it a certain way, do it. Or that's when you'll be cited. So that's my word of advice. Okay, so the next standard that we're going to look at is 020403. Again, the general standard says you inspect, test, and maintain medical equipment. And there are a lot of elements of performance under that. And it addresses inventory and alternate equipment maintenance schedules and so forth. By the way, CMS says alternate equipment maintenance is not applicable to imaging equipment. So you can't do that. Again, you're stuck with the manufacturer's instructions. And this is pretty much, you made a plan. This one says you're going to follow it. So those two elements of performance and standard go hand in hand. So 02040110, that's your plan. Now they're going to say, do it. So what's going to happen? When they interview the staff, they'll say, again, do you know what your plan is for this piece of equipment? Can you show it to me? Who does these tests? And how do they do them and when? Again, what they're going to be looking for is if you say you do something daily, weekly, monthly, do you have evidence that you're doing it daily, weekly, monthly? And if you're not, it's kind of the old NRC approach. If any of you guys are old enough to remember when the NRC came in and went through your books line by line, and if you missed day, 47, you got dinged. And well, some of the surveyors are doing that. So they're going through and they're looking to see if, in fact, you're following what you set out. And the other thing they're going to say is, okay, so this is supposed to support a quality image. How do you judge? How do you judge that you are producing a quality image? So do you have some kind of a review mechanism? And again, what they're going to do is look at your logs. If you say you're doing it, show me you're doing it. And a very late slide at the end, I asked them to pull for me a report of all the citations that have occurred with the diagnostic imaging elements of performance, because the standards get lots of them, but the elements of performance since July 1st, 2015. And they are citing, I went through the log, they said they'd do it weekly, they missed a certain number of days, so they're getting scored for that. So they will be looking at the logs. Okay, and this one is another environment of care, EP17, and this one has the medical physicist tasked with measuring the CT-DI vol. I know all the issues surrounding that. We're nowhere near talking about, is it meaningful on today's scanners? But anyway, it has to be measured. Have to measure it for 4 protocols, adult head, abdomen. If you do ped work, ped head, ped abdomen. If not, 2 other imaging protocols of your choice. They'll ask you why you picked those other 2. So, you probably are going to say things like they represent higher dose or they represent higher volume. So it's up to you, if you don't do ped work, to pick 2 others. And then the physicist is going to look at what he's measuring, and he's going to look at what's displayed, and they need to be in agreement within 20%. I've talked to MITA. I know that they've got some real issues with that number, but it's our opinion that scanners should be able to meet that 20%. Now, one of the things, do we have a lot of physicists? Yeah, a fair number of you guys. So, MITA's big deal was, well, we very specifically have a procedure for measuring and what's displayed, and if the physicist doesn't do it exactly the same way, they could be outside 20%. So what do you have to say about that? Well, I have to say, we're not dumb. Tell us how you did it. We can measure it that way. Give us a break here. So, again, 20% is it, no leeway. Got to be within 20% of what's displayed. And I believe that's the California reg, isn't it? 20%, I think that's written in the California regs too. Okay, so again, process interview. Hey, wave at me because, again, I can talk forever. I need to get through this. So is there a process to measure it? Who does it? What protocols? And here's a biggie that they like to ask, what are you going to do if it's outside that 20% limit? What's your process then? What steps will you take? And so you need to be able to show that you understand why you're doing it and what you're going to do if it's outside. Now, here's a couple things. I've been asked, particularly when these first came out, does that mean that this all had to be done by July 1st, 2015? The answer was no. This was an annual requirement, so it had to be done by July 1st, 2016. So if, for whatever reason, you've never had this done on your CT scanner in your accredited organization, you got a couple months to get that particular requirement met. And the other kicker here is it's got to be done by the diagnostic medical physicist. Now, the Joint Commission has really only defined the qualifications for 2 individuals at this point in time for imaging. One is the diagnostic medical physicist who supports CT services, and some standards that are due to go into effect September 1st, which deal with the diagnostic CT technologist. So, and I'm sure I'll have questions about that, and I'm prepared. So anyway, this does say that the diagnostic medical physicist is the individual who has to make those measurements. Now, I throw this up here because, again, there is a conflict between what the Joint Commission recognizes and what the ACR recognizes. So if you've got an ACR-accredited CT scanner, and, for 40 years I did ACR accreditation at my organization, so I know ACR, and every time I mention that, they look at me and say, we are not the ACR. I know. Anyway, the ACR gives you 14 months, right? 2 months on either side. The Joint Commission for an annual requirement only gives you 30 days. So if you're on an ACR schedule, for instance, with your consultant, you could be outside the Joint Commission window, and you'll get scored for that. So make sure that you're within that plus or minus 30 days of the last occurrence so that you're meeting the annual requirement. Okay, another environment of care, those annual performance evaluations. There's the list of tests for the CT scanner, probably things that are already being done. Some of the names are a little different than maybe what you would see in the ACR list. As a matter of fact, I've done a couple of educational sessions for the Joint Commission staff, and I've actually put, like, here's what the ACR calls it, here's what the Joint Commission calls it. Be able to cross-reference, don't say they're not doing this just because they called it something different. So we're working on that. And again, just a little hint, these are surveyors who are not imagers, and when they look at a report, if the report's in the order that it's in the standard, that makes it really easy for the surveyor to say, yeah, it's being done. So you, as a consultant, you might want to make sure your forms match that. Again, we're going to be around every 3 years, so you're probably going to want to make sure you get that. Okay. EP19 for element of care 020403. Again, with these performance evaluations, Particularly for the CT, we very strictly define what a diagnostic medical physicist who supports CT services is, but medical physicists are accountable for that performance evaluation. They don't have to do all the tests themselves, nor do they have to be present when the testing is done. However, the medical physicist has to have approved the training and qualifications of the person who's doing the data collection for you. So if you are, for instance, in a consulting group and you've got some individuals in your group who meet that definition of a diagnostic medical physicist and others do not, as long as the individuals who are in your group and do not do it under the diagnostic medical physicist's guidance, then that's acceptable. So that's a little different between the ACR and the Joint Commission. With the ACR, the only modality that I think the physicist doesn't have to be there, at least was, I don't know if they've changed it, is nuclear medicine. And otherwise, the physicist has to be there and collect the data for all the other modalities. The Joint Commission says you're accountable, but you don't have to be there. So now the people. Interpreting physician, medical physicist, health physicist, CT technologist, and your vendor. The interpreting physician is an element of performance that we're working on now. They're talking to they've got so many acronyms, honest to God. I listened to a meeting with my fellow engineers, and they're all wonderful engineers that I work with, and they were talking about Psalm this and Psalm that. I'm thinking, what, Psalm 23? What are you talking about? It was standard operating manual for CMS to the states. Well, it took me 20 minutes to figure out what the heck a psalm was. So they have lots of acronyms, and they have groups called PTACs and PSAGs, which are experts that they pull together, professional and technical something group committee. And so they have really great people that come together and provide input on these standards. And they are looking at qualifications for individuals interpreting CTs. And, where they're going with that, I don't know. They're just starting to work on that and not focusing on radiologists, of course, but on the other physicians who might be interpreting outside. And I'm old, I forget the numbers, but there's a really pretty high percentage of CTs that are interpreted by non-radiologists. And, we want to make sure that medical staff who are giving these individuals privileges have some guidance, that they're not just saying, okay, so we'll be working on that. Medical physicists were covered. I don't know if we'll be talking about qualifications for an MR scientist or a nuclear medicine physicist. They haven't really started talking about that yet. Again, CT technologists, there are some standards that are scheduled to go into effect in September. And of course, the vendor is a valuable resource for you. So, medical physicist. These are the qualifications as defined in EP 20 of HR 010205 and board certification. By the way, I pointed out to them that they've got the board certifications that are acceptable for D.A.B.R. there for the medical physicist, and I'm a diagnostic radiological physicist, which is an abandoned title now. It's diagnostic medical physicist, and they didn't have that in the list, but they understand that I think that's been the title for about the last 5 years. So you can be board certified, or you can meet all of these qualifications. Now, generally speaking, nobody has trouble with the graduate degree or the coursework. The problem that some individuals have is with the essentially proctored 10 CT performance evaluations. If you're somebody like me, I got board certified mostly because of mammography. Otherwise, it really didn't make any difference to my pay or responsibility or anything else, but I got board certification. But there are a lot of people my vintage that did not, but they're very knowledgeable and experienced, and I would trust them. They either taught themselves Or, as one guy said, well, the person who did this for me is dead. What do I do? So I don't know. So the idea here is to somehow get some documentation to show that you're qualified to do this and that somebody's reviewed. I know it says direct supervision, but that somebody's reviewed your report. So here's what I said. Gosh, I hate this on tape. But if you're a physicist and you can't meet that 10 for the Joint Commission, but you've been doing ACR accreditations and you've had 10 successful ones, a board-certified physicist reviewed your work. So document that you've had this review and that you have successfully performed these performance evaluations. And I've had that crop up a couple of times when a surveyor's been on site and said, I got this problem, what do I do? And I've said, have they been doing accreditations for their equipment with the ACR? Yeah. Well, have they done 10 of them? Yeah. Did they all pass? Yeah. Well, then this guy is, or girl, is, adequately trained and experienced. So I think that the surveyors are okay with that as long as you show that there's some evidence that the person providing that service is indeed qualified. Okay, I better move along. So again, interview, they'll either talk to the physicist or to the staff, ask who's providing those services, what their qualifications are, probably ask to see the file on that individual. By the way, if you're using a consultant, it doesn't have to be in the hospital, as long as if they ask for it, you can somehow send it over, provide it. That would be good. And people have said, okay, so what about the other modalities and the individuals who support those? Right now, they fall under HR 10205, which says that the organization verifies staff qualifications. So it's up to the organization to say, here's the requirements for the education and experience of the person providing those other services. Now, and we're not, right now, actively working on definitions for MRI scientist or nuclear medicine physicist. Let's see. Okay, here's the biggie. The hospital verifies and documents that technologists who perform diagnostic CTs have annual education and training on dose optimization and the operation of their scanner. And in the document itself, it references image gently and image wisely. Those are nice resources. Those are not the only resources. There are other opportunities for education and training for the technologists, and any of those are acceptable. So you can use education that the technologist has gained for their continuing certification through ASRT. If the vendor's providing education, if you want to put something together yourself, that's fine, as long as it addresses dose optimization and there's a segment that talks about the safe operation, so they know what they're doing with the scanner they're using. So that's the important thing. The reason it's annual is because software changes, hardware changes. We want to make sure the tech's not, 2 generations behind. So that's that. Again, they'll say, what kind of training did you get? When did you get it? Who got it? And show me what you got. So documentation, my thought when people say, okay, what kind of documentation? Put down what was covered in the educational session and, how it was delivered. It can be online, it can be written, it can be in person. It's entirely up to the org. And again, then they'll review the documentation to make sure it's being done. Okay, so now let's go into processes. Documentation of the CT radiation dose index in the patient record, essentially. And all we say is that it's got to be specific for the site or series, and it's got to be readily retrievable, and it's got to be whatever dose index your organization chooses. Probably CT-D.I.V.R. or SSD, because those are the 2 that show up. If you've got PACS, that last sheet in the study that's attached to the images that goes into PACS meets this requirement. So you don't have to do anything else. You're good. If you don't have PACS, and you got a log, that's fine. It's up to you. Or a separate spreadsheet, it's up to you. We're not saying that you have to get a PACS system if you don't have one. Not saying that. We just say you need to track the dose index and needs to be readily retrievable. So again, the interview, well, what's your process? How do you measure it? Which one? What index have you chosen to document? And how do you retrieve it? And then, they'll probably pick a patient, maybe the one they're tracing if that patient's had previous studies, maybe one completely at random, and they'll say, okay, pull the dose index information for this patient. So, can you retrieve it? We were talking last night about some of the issues with the PACS systems and the fact that there have been glitches and some of the data's been lost. And somebody said, well, 90% of the data. It's not what the Joint Commission standard says. It says every exam. So, if you've only got 90% of your data flowing into PACS or it's getting lost, just hope that's not the patient they pull, because the Joint Commission standard says all of them. Okay, patient care 10215 EP10. This says that before you do the CT, you have to verify you've got the correct patient, the correct imaging site, the correct positioning, and then for CT, the correct protocol and scanner parameters. So people said, do I have to have another form for this? Do I have a check sheet that I check all those? No. This is a process that should be documented. So in your policy, you ought to have a policy that says, as part of the intake process into the CT area, we check these things. That'll satisfy the surveyor. So again, interview, what do you do when you bring a patient in? What do you check? And they should be able to list those 5 things. And then, so it says you're going to check the CT setup. How do you know what that's supposed to be? And that kind of flows into the protocol piece. So, do you know where to find that? And then do you know how to set those parameters on the CT scanner? And then, again, they're going to probably watch them. They'll watch them bring a patient in, make sure they do that. A couple of orgs have been scored because they did not do any of that when they brought the patient into the area. And when they asked the tech, where's your policy on that? They said, oh, we don't have one. Wrong answer. So they got scored on that one. Again, what we're trying to do is balance the risk versus the benefit. We want to have more benefit than risk. And, we're talking about dose optimization, but the best way to save dose is just not to do a study that's not indicated. And so when I was doing some research here, the IAEA said that about 30% of CT scans are unjustified and could be avoided. And so, again, I think that this is going to be an area that everybody's looking at. And the same federal rule that gave us XR29 has decision trees as part of that, which got postponed. So we're going to all be looking at that. You can bet if Medicare and CMS is looking at that, the Joint Commission will be shortly as well. So again, another process standard. Patient's age and previous imaging exams are considered. This one's a hard one, I think, from practice, because if you have an electronic health record, it's probably pretty easy for you to know what they've had in your organization. But unless you're part of a network that includes other organizations, you don't know what those people have had other places. And we were having a discussion last night about how patients lots of times don't know what they've had or why they had it. So, this is a hard one. But the point here is that we're trying to avoid those studies that are repeated because physician A ordered it, and now they've seen physician B, and B doesn't know A already did it. There's been no change in the condition or diagnosis, so you don't really need to repeat the exam. And that's what this is looking at. Again, how will an organization meet it? They're going to write a policy, and there will be some sort of process that undoubtedly the tech will say to the patient, have you had a CT recently? And hopefully they'll say yes or no truthfully, and then you can explore it. The other thought here is that you'll have a process to get the radiologist or imaging physician involved. So for instance, if the ER is ordering a CT for appendicitis on a kid, and maybe it would be more appropriately done in ultrasound, there's a process where the tech knows to go talk to the radiologist to see if he needs to talk to the referring physician and see what's the more appropriate exam. So that's the point of this particular element of performance. Again, they'll talk to the staff. They'll say, you know, how do you get information about what kind of prior testing the patient's had, and what do you do if you find out that they have had this? Or, you know, CT techs know who's been in, you know, 5 times in the last 3 months. They know that stuff. So give them direction. Let them know what they should be doing when they observe that. And again, they'll look at how the patient comes in, whether they do ask the patient those questions, and you know, what kinds of considerations go into the patient evaluation before performing the exam. And again, they very specifically say recent and relevant, so if they had a head CT today and it's an abdomen tomorrow, you know, that wouldn't apply here, and that's common sense. Okay. Establishing or adopt CT protocols, and I cannot wait to hear the other speakers talk about how you can do this, because this is a big job. And it's not like we don't have any protocols. Everybody's had protocols. For the Joint Commission, the piece that's been added, I'm pretty darn sure everybody's protocol included everything that was up there, except maybe the expected dose index range. That's a new one. And again, that's to bring to mind, you know, you're supposed to be optimizing this dose. So you need to know what to look for. And I understand how difficult it is when you have hundreds of protocols. So I really will be very anxious to hear the speakers talk about how to meet this one particularly. So again, interview, do you have protocols? How do you modify those protocols if, you know, imaging is a science, but it's also an art. And you got to be able to understand the art of it to do an exam appropriately. That's my opinion. And I think that the imaging technologists are artists, really. And when you get a good one, you've got something golden. Hang on to them. So how do they adjust for patient size, body habitus, disease condition? How do they know what to do? So they're going to ask them that. And then they'll look at protocols. Again, I didn't write down all of the scoring descriptions, but at least in one organization, they had protocols, and the surveyor said, okay, for this exam that they were following the patient tracer, show me the protocol. They did. Then they watched what the tech set up. It was entirely different. And they said, wait a minute, how come you're not following this protocol? Well, that's old. We don't do it that way anymore. You know, guys, you're asking to be scored. So again, make sure your individuals who are doing these things understand what's out there. So again, they'll watch, they'll ask questions. Okay. Once you establish them, you got to review them and keep them current. Again, as equipment changes, as knowledge changes, as algorithms change, you got to update. That's what this is. It's trying to say, just because you were there 4 or 5 years ago doesn't mean you're there now. So, you know, you need to review your protocols. Notice we don't tell you with what frequency or how to do it. We do tell you who needs to be involved. the physicist, the imaging physician, and the technologist. Those are the three. Anybody else, it's wonderful if you add them, but at least those three have to be involved in reviewing the protocols and updating according to what's out there as standard of practice, state of the art now. So again, keep them up. What's the frequency of review? Now, I've said, okay, so what's good, guys? What are you guys looking for? And they said, well, you know, annual is wonderful. If you went longer than every 2 years, surveyors would look at that askance and say, I don't think so. If you've got a revolving kind of timetable for reviewing your protocols, you know, you do so many this quarter, so many the next quarter, and so forth till you get them all done, perfectly acceptable. But, you know, again, what is your organization's policy on this? And make sure that you're following it. So if you say you're going to review them all annually, you better have evidence that you've done it all annually. If you know, it's every 2 years or whatever your process is, define it for the surveyor, and then they'll verify that you're doing what you said. So again, they'll ask the process, they'll ask the timetable, they'll say, show me some. Okay, how am I doing? How much time do I have? 5 minutes, okay. Well, that's good, because I'm almost at the end. Here's the last one that really people are now coming to grips with, and this is the performance improvement standard and element of performance that says for every exam, notice I use the word every, for every exam instance where the dose index fell outside your expected range, you have to collect that data and follow up on it, you know, analyze it, in other words. And so people are starting to really take this seriously. Again, notice we don't say, you had to start July the 1st, 2015. But as far as the review, you know, how often you did that, what your process was for it, it's up to you. It's very helpful if you've got software, but we're not saying you have to have software. You can have a completely manual process to do this. But the surveyor is going to say, how do you know the manual process works? So, you know. And again, when I was doing research, here's the FDA's comments on that. And I just thought it was noteworthy, and you probably would like it to read at your leisure. So there you go. They talk about how tracking events, and wasn't there a paper just published that when you tracked events as far as dose index, then they saw a trend downward. So, you know, it's very helpful in keeping at the top of the operator's mind kind of thing. Oops. Okay, so again, they'll ask, were there any incidences? How did you handle them? When you analyzed it, were there any actions that you took? And if you go back to the standard, it says that your expected dose range and the values that you're looking at have to be benchmarked. And that's where the next speaker is going to help us with that. How do we get that? So, you know, again, we, as the Joint Commission, we want to say, don't just say, oh, yeah, I'm doing fine, you know, or my 2 or 3 hospitals in my network, we're doing fine. When you may be outside what everybody else is able to accomplish. And so, again, that's the whole point of the standard, how you get there up to the organization. So they'll look at the data you might have collected. They'll look for evidence of benchmarking. They may ask why you chose that particular benchmark. What was your reasoning for that? And they'll look for anything that you did with that data. Okay, so lots of words here, and I'll kind of go through these pretty quickly. But again, the Joint Commission is a deeming organization for CMS. And I wasn't really terribly familiar with all the CMS requirements before I took this job, but I've spent a lot of time reading them. And if you look at some of the Joint Commission requirements, they're very, very similar, almost word for what you find in CMS. So again, it's not just the Joint Commission who's saying these things are good to do. It's other major accrediting organizations as well. So again, this is out of that SOM, not SOM 23, but the Standard Operating Manual. These are some of the instructions that are being given to CMS surveyors. So, if you have a CMS survey, they're going to be looking for the same things the Joint Commission is. And I put this up here. This is the data that we've collected since July 1st, 2015. So when I first asked them to pull some data for me, they had data from the initiation to November the 30th. At that point, the elements of performance that pertain to diagnostic imaging, I asked them to pull the scores for organizations that were scored for those. There were 34 total. It's not a lot. It doesn't seem like a lot. Again, surveyors have been educated on these diagnostic imaging standards. They're becoming more comfortable with them. And so they're, not surprising, there weren't a whole lot of scores in that first, whatever it was, almost 6-month period. There were no organizations that were scored on the review of dose index being outside the range at that point. So, to me, that says the surveyors weren't comfortable with this. So they really didn't know to look. From November through March, again, from the initiation till the end of March when they pulled the data for me, there were 61 scores. So first of all, it tells me the number's going up. So the surveyors are getting more comfortable. They're looking a little harder at organizations for these elements of performance. And now there were 2 organizations that were scored on the performance improvement standard, which was the looking at the incidences of being outside. So the point is, they're learning more, they're going to ask more questions, they're feeling more comfortable, and be prepared because they will be looking for that. So those were the CT ones. By and large, when I looked at all of them, the majority of the scores were in MRI. And it's because there were a couple of things it's kind of like lead aprons. They're easy to see. So you either have the sign with the verbiage or you don't. You either have access control to the door to the MRI room or you don't. You either have a non-ferromagnetic fire extinguisher outside in the hall or you don't. Those were pretty easy things to look for, and that's what the surveyors were finding initially. But I'm seeing an uptick in the CT. I haven't seen a whole lot in nuclear medicine or PET so far. So let's see. I think that's the last, almost. Oh, again, I was doing research, and I listened to an absolutely wonderful webinar that they had some really good speakers, and they were talking about dose and risk and benefit and so forth. And Dr. Morin, is that how you say his last name? Morin? I know his name, I don't know him. Anyway, he said, we learned it in kindergarten when somebody's watching, behavior changes. So, the Joint Commission is watching.